Okay. Well, good afternoon. Good afternoon, everyone, and thank you for joining us here in the Washington, D.C. office of Mathematica, and welcome to all the folks who are joining us online as well. My name is Jonathan Brown, and I'm Associate Director of Health Research here at Mathematica, where I also oversee much of our behavioral health work. And it's my pleasure to welcome you today to our Disability Policy Forum that's going to focus on efforts to coordinate health and housing services for individuals with behavioral health conditions. As many of you know, the Center for Studying Disability Policy was established in 2007 to help build the evidence base for sound, effective disability policy. And in addition to the research that we do, we host these forums to help share our findings so they can be used to improve disability policy and programs across the nation. You might also know that Mathematica has a long history of conducting research and evaluations that are focused on improving the quality and outcomes of care for individuals with mental health and substance use disorders. And much of our recent work in this area has focused on helping federal and state policymakers find ways to improve the coordination of care and care transitions within the Medicaid program. As we'll hear about today, the findings from several of our projects have underscored the importance of ensuring that individuals with serious behavioral health challenges have access to affordable and stable housing, and that their services are well coordinated across physical health care, behavioral health care, and other social services. And we also know that we need better models of care and reimbursement strategies that support transitioning people from institutions into the community, bringing services to individuals who are in housing programs, and coordinating care with housing providers. As you all know, in many states and communities, housing, health, and behavioral health services remain provided through entirely different funding streams and through different agencies. And unfortunately, there's often little coordination or communication either at the ground level or at a policy level. And as we'll hear more about today, in many communities, affordable housing and housing programs for this population remain in short supply. So that's the problem, but today we want to talk about some of the emerging solutions and the policy developments in this area. As you might know, in recent years, CMS and HUD have collaborated to encourage states to adopt policies that will increase the availability of home and community-based services, as well as supportive housing opportunities through various initiatives that some of which we'll hear about today. In addition, CMS has encouraged states recently to be creative in how they use various waivers and coverage options to reimburse care coordination services and facilitate behavioral health and medical providers working together with housing providers. So today we're going to highlight a few of our findings from recent and ongoing projects. First, Carol Irvin will describe how the Money Follows the Person demonstration has worked to improve the availability of supportive housing for Medicaid beneficiaries who are moving out of institutions. Dr. Irvin is an Associate Director of Health Research at Mathematica, and she has substantial experience evaluating programs that extend coverage to transform healthcare services for people of all ages, especially those with chronic conditions and disabilities. Next, Matthew Keene will discuss some innovative state strategies that are being used to better coordinate health and housing services for people with behavioral health conditions. Mr. Keene is a researcher here at Mathematica who studies Medicaid programs and initiatives for people with disabilities, including those that are aimed at improving access to care and care coordination. And finally, we're very honored today to have Jennifer Ho here to discuss how the U.S. Department of Housing and Urban Development is working with other federal agencies to coordinate health and housing services. And Ms. Ho is the Senior Advisor for Housing and Services at HUD, where she manages the department's work to connect housing with health and social services. And she leads efforts aimed at ending homelessness, defining the needs of an aging population, and meeting the housing needs of individuals with disabilities. So before we get started, we just have a few quick housekeeping reminders for the audience. As you know, we have both an in-person audience and an audience online on the webinar. For folks on the webinar, you can submit your questions on the Q&A panel that's on your screen at, excuse me, at any time during the forum. And after the presentations today, we're going to alternate taking questions from the online audience with those folks who are here in the room. And for folks who are here in the room, if you will, please take a moment to make sure your phone is silenced and know that we are video recording, and we're going to post this to our website in the next week. So with that, I'll hand it over to Carol.
Thanks, Jonathan. I'm happy to be here today. Mathematica, for about 9 years now, has been under contract with the Centers for Medicare and Medicaid Services, or CMS, to evaluate the Money Follows the Person demonstration. And the work I'm going to be presenting today, almost all of it is from that contract, except with a couple exceptions, and I'll point those out. In any event, what I want to start out before I get into the meat of my discussion is to make sure everyone, I went the wrong way, to make sure everyone has a basic understanding of what the Money Follows the Person demonstration, or MFP, is. It's a Medicaid demonstration for individuals who have been residing in institutions for long periods of time. In this case, it means at least 3 months. And the idea of MFP is, first and foremost, is to move people out of institutional care and into community settings. And that's what the logo here for the program tries to depict. And the way in the principal underlying aims of this demonstration is to help state Medicaid programs figure out how to reduce the reliance on institutional care for people who need long-term services and supports, to help them develop more opportunities for community-based long-term care services, and ultimately to enable people with disabilities to participate more fully in their communities and have an improved quality of life. Now, I want to make sure everybody has a basic understanding of exactly how they achieve these aims. First and foremost, as I mentioned, the programs are there to transition people from institutional care into community settings. So that's the first step. Once they're in the community, though, the program is responsible for providing long-term services and supports, which will include housing supports. And when they provide those particular services, then the Medicaid program earns enhanced matching funds from the federal government. And the last step here is that they need to take those enhanced dollars and plow that back into their community-based long-term care system to provide better access for those kinds of services. And I bring all this up because a lot of the strategies that the grantees have been using that I'm going to be talking about today are either financed through a direct provider billing Medicaid for the service or billing the grant for the service, or using these enhanced matching funds to pay for what they're doing, their strategies. We happen to call these funds the rebalancing funds for these states. So the MFP demonstration has been extremely popular. Today, there are 44 states and the District of Columbia who have active programs. And as of the end of 2014, they had transitioned nearly 52,000 people. And I've got to learn which arrow to hit. The states have been transitioning people with all types of disabilities. So about a little over a third of the individuals they're transitioning right now are older adults. These are individuals living in nursing homes. But they are also, about a little over a third are also younger adults that they're transitioning out of nursing homes as well. The balance are individuals with intellectual disabilities, mental illness. The housing that these individuals move into then is also as varied as they are. And each of the targeted populations or major populations that the programs are transitioning tend to flow into different kinds of housing arrangements. So for older adults, people over the age of 65, they are tending to move into homes either that they still own or that family members own. Younger adults with disabilities and those with mental illness are tending to go into apartment types of living arrangements. And then people with intellectual disabilities are predominantly moving into small group homes. MFP has a requirement that the small group home can be no more than 4 people. So these are truly small group settings. Now, I presented these 2 slides because I wanted you to get a sense that these programs are dealing with a diverse array of individuals with a wide range of needs. And they are moving into very different and the full range of housing situations in the community. But the programs have had their challenges running these programs. And the two challenges that we hear most often in their semi-annual progress reports is one, the first one that we've heard since the very beginning of this demonstration, is that there's a lack of affordable and accessible housing. And many of the grantees will tell you that if there was only a better supply of this kind of housing, we could transition more people. They will also cite insufficient services, particularly for those with mental illness and behavioral health needs. And I want to go into each one of these challenges in a little bit more depth. So on the housing challenge, one of the first issues is that we're talking about a Medicaid population, been in institutional care for at least 3 months, although many have been in there for years. And they have very few resources, little wealth, if any wealth at all. And so they don't have a lot of financial means in which to go out and secure housing for themselves. The housing subsidies that are available, the demand for these subsidies outstrip the supply of them. CMS and HUD have collaborated on 3 different programs. One starting called Project Access in 2001, which was a pilot program to pilot test the collaboration between housing authorities and the health agency in a state. The next one in 2011 was the non-elderly disabled Category 2 vouchers. And these were vouchers that went out to, I think, 13 different states, and all but one had an MFP program. And in those states, MFP and the housing agencies collaborated together to lease up those particular vouchers. And now today, there's the Section 811 program that is plowing quite a bit of money into the states to help them establish subsidized supported housing. And this program also has a requirement that health and the housing agencies in the state need to collaborate to participate in the program. But as you can see from the numbers on here, these are relatively small numbers against the demand. I mean, nowadays, currently MFP programs are transitioning anywhere between 10 and 11,000 people each year. On the service side, then, if you will remember back to the pie chart that I showed you just a moment ago, grantees are telling us that about 9% of the individuals that they transition have mental illness. But when we go into the service history of these individuals who are participating in MFP, we look at their claims for different kinds of health services that they access. We identify about 60 to 65% are receiving some kind of service for a behavioral health or mental illness condition. So that needs for behavioral health services are common within the population being transitioned by these programs. And what the grantees have found is that their transition coordinators are not always well trained to deal with people who have these kinds of needs, so that they've required some specialized training to bring them up to be able to serve people with mental illness and behavioral health conditions well. In many of the states, they have mental health providers come in and train their transition coordinators on how to provide services for this population. In the case of Ohio, they've done it a little differently, where they're recruiting and hiring behavioral health providers to be transition coordinators. So how are states handling the housing challenge? What kind of strategies are they using to address the various barriers that they see? And we have actually, based on our research, come up with 4 categories of strategies. The first one is collaboration. A lot of programs are working hard to collaborate between health and housing. The second strategy is working to increase the supply of community-based housing options that are affordable and accessible. A third strategy is providing simply more housing supports to this population. And then the last one that I'm going to cover is tenancy support. So once you get somebody into a community-based housing, providing supports to help make sure that it's successful for them. So going back to the first strategy, promoting long-term collaboration between health and housing. We have at least 21 grantees who report to us on a fairly routine basis that one of the key outcomes of the MFP program in their state is that they've been able to develop stronger interagency collaboration, particularly with local housing agencies. I've noted already that the HUD and NED 2 housing vouchers was a good vehicle by which the states that participated in this program were able to bring health and housing together to provide, to lease up these particular vouchers. My colleagues, Denise Hoffman, Deborah Lipson, and Matt Keene, who's up here, did some work for ASPE looking at the results and the impacts of the NED2 vouchers. And based on their research, their data suggests that these vouchers were able to support transitions that probably would not have occurred otherwise. CMS has also stepped up and provided grants to 6 of the MFP programs to help them develop and strengthen their Medicaid and housing partnerships. And then on their own, states are doing other things such as working with local housing agencies to get MFP participants priority on waiting lists. Mississippi, Missouri are example states here. In terms of what they're doing to increase the supply of housing options, I have to remind people that Medicaid cannot finance bricks and mortar. But what they can do, and what MFP programs have been doing, is one is advocating at the state level for more financing and more investment in housing, affordable, accessible housing. They've also now getting quite active in support of housing with the 811 program. Several states are also trying to work hard on addressing the shortage of small group homes. In some cases, again, this is advocating for informed financing, but we have a state like Connecticut then that's working on establishing a roommate matching service. And then lastly, they're also working on modifications to existing units. Here again, Ohio is working with a nonprofit to install modular ramps, and that's just one example of some of what the states are doing to help with modifications to homes. In terms of increasing and providing more housing resources, here we have 3 different kinds of activities grantees have been pursuing. One, and a fairly common one, is the information resources that they've been putting out to stakeholders. A lot of this is web-based, putting out housing registries, things like that. And Louisiana, Tennessee are examples here. Another big one, a really critical one, is the housing specialists. Grantees have been using their rebalancing funds to hire housing specialists. In some states, this is a single individual who works on policy at the state level between the health and housing agencies. And these individuals will also go out and do, say, education for transition coordinators on housing resources, and then they will go and educate housing staff on health and community-based services that people can access. In other states, though, they're going out and hiring a group of housing specialists who work one-on-one. And in these states, what happens is that you're working with a transition coordinator who sets up your services for you, and then a housing specialist who helps you find and locate and secure appropriate housing. And then lastly, we have some states, Illinois, Connecticut are examples here, where they have been able to secure state financing for bridge subsidies. So this is the case where you have somebody who wants to transition, you've got a unit for them, but the federal subsidy is going to take a little while to come through. The state goes ahead and transitions them anyway and pays the subsidies out of state funds for that. Then lastly, grantees are also doing a lot of work around providing tenant assistance and support, helping them address personal barriers such as missing documents like Social Security cards, addressing bad debts that they may have that may prevent them from entering in another lease. Several states are also providing small financial assistance right at the time of transition to help them with those incidentals that happen, help you set up a pantry and other kinds of one-time moving expenses. They will also work, and states have also finance improvement in housing for environmental purposes. They've also worked with participants to help them improve their independent living skills, like around medication management, how to be a good tenant. And then stabilization services. This is where states like Ohio, Louisiana, I believe, have learned maybe the hard way that during the first 90 days in particular, people are pretty vulnerable to returning back to facility living. And therefore, during this period, they will go out and do extra visits to make sure that all the services are working in the way that they need them to work, and tweak things if it needs tweaking. So I want to wrap up with some key results then from the program. Essentially, to try to give you a sense of whether or not all this work that the state, what's the outcome of all the work that the states are doing around not housing, but all the other services that they're providing. And the first piece of evidence of some of the success the program is having is shown among younger adults with physical disabilities. And this is the one group where we find that MFP is associated with an increase in transition rates. And in fact, we estimate that by 2010, which is about the third year states were transitioning people, approximately 95% of the individuals transitioning in this population probably would not have made the transition without MFP. And remember, this is a population that's using, or primarily going into apartments, so that they're prime candidates for some of the subsidized housing that's available to people. And then the other piece of that I want to cover is quality of life. We're seeing very large improvements in the quality of life of MFP participants after their transition. Grantees are required to conduct a quality of life survey at 3 different points. Once right before somebody transitions to the community, a year after that transition, and then 2 years after the transition. And we look at 7 different domains of quality of life, but the one that I want to draw your attention to is on the right side of this graph, and that's with the satisfaction with their living arrangements. This is the domain where we see the largest improvement in quality of life. We see a 32% increase in people reporting being satisfied with their living arrangements a year after the transition, and they sustain that high level of satisfaction 2 years later. So whatever the states are doing around housing, it seems to be working, at least at this level. CMS is taking a few steps to sustain the momentum of what MFP has started. First and foremost was last year, they sent out an informational bulletin to Medicaid programs, reminding them, clarifying for them that the kinds of housing supports Medicaid can reimburse for, that several of these things are at the level of the individual to help with transition services and also tenancy sustaining services. And then Medicaid can also help provide for some of the collaborative activities between health and housing as well. And then lastly, CMS has established a new program called the Medicaid Innovation Accelerator Program, or IAP. This is a technical assistance program to state Medicaid agencies, and a state can get assistance in 4 different topics: substance abuse disorders, beneficiaries with complex needs, and then integration of physical and mental health services. But the last category is community integration, and this is where they are providing technical assistance on housing supports. They are doing 2 areas of supports, one having to do with housing tenancy, and the other one was state Medicaid agency partnerships. And I understand that there are 30 states that are set up and receiving technical assistance on the housing tenancy side of it. So popular program. So with that, if you're interested in learning more about MFP and our research, here's email addresses for our partners at CMS, as well as myself, and the websites where we house our documents. And then I've also included a list of references that I use for today's presentation. So thank you.
afternoon. So, as Carol noted, CMS and state Medicaid agencies are particularly interested in identifying ways to improve care coordination or to improve coordination between housing and Medicaid services. And through the June 2015 informational bulletin that Carol referenced that CMS released, there's a copy of this bulletin for those here in the room in your packets. Through this bulletin, CMS encourages states to use existing authorities to do this, to explore ways to do this. And we've seen several states and local jurisdictions adopt initiatives that move in this direction. And what I'll do in this presentation is highlight 2 state examples of this. So the 2 case studies that I will discuss stem from some work that we did for ASPE, the Office of the Assistant Secretary for Planning and Evaluation, between 2013 and 2015. So I'm going to briefly just present some background information on this study. The rationale underlying our study is listed here. What I want to highlight is our study's purpose, which was to conduct case studies of states using innovative strategies to coordinate care for Medicaid beneficiaries with mental health and/or substance use disorders. And we were particularly interested in those initiatives that also attempted to coordinate housing with these Medicaid services. I list here the state selection criteria we use to select the states to include in our case studies. Also, our data collection efforts, which included phone interviews with representatives of state Medicaid agencies, as well as representatives of managed care organizations. And we conducted site visits to both states where we interviewed various providers, members of the workforce, and consumer representatives to really try to get an understanding of what these initiatives looked like on the ground. So let me start with Illinois. And in Illinois, we focused on the initiative that established care coordination entities, or CCEs. And simply put, a CCE is a formal network of pre-existing community-based local organizations that collectively are providing care coordination services to enrollees. So, and we'll get into the details of this. So first, some important background information. Underlying this initiative is the state's belief in 2 things. One, that people with serious behavioral health conditions require intensive in-person care coordination. And 2, that these types of intensive coordination services are best provided by local community-based organizations. So the state is moving towards mandatory managed care, but there was a belief in the state that the telephonic approach to providing care coordination that's often used by managed care organizations is not effective at engaging this population. These are individuals who are often isolated from health and social service systems. So the idea underneath the CCE model is that community-based providers are best situated to understand the needs of this population, of the local population, and they're best situated to understand the local resources. So in late 2013, early 2014, the state of Illinois established or approved 3-year contracts for 6 regional CCEs. They auto-enrolled, so the state auto-enrolled between 1,000 and 1,500 Medicaid beneficiaries into each of these 6 regional CCEs. And they selected the highest cost Medicaid beneficiaries, particularly those with serious mental illness and/or substance use disorder, many of which are homeless or unstably housed. And this is a small number of beneficiaries for sure, but again, the logic here from the state's point of view is that in order to create an effective model, these entities needed to focus on a small population. So what does a CCE actually look like? And across the 6 CCEs, there's some significant difference, but all of them included various community-based providers, including the types of providers shown in this figure. So mental health providers, physical health providers, hospitals, pharmacy chains, substance abuse service providers, social service agencies, and housing providers. One of these providers was designated as the lead agency, and they were primarily tasked with handling administrative responsibilities for the CCE. The number of providers in the CCE also varied So as part of this review, we visited 2 CCEs. One of them was in Chicago and was comprised of 34 different provider member organizations. The second one was located in Decatur, which is in downstate Illinois, and that one was only comprised of 6 provider member organizations. So we see structural differences in how these CCEs are formed. Again, the providers, the individual providers existed before the CCE. What is new is the way they work together. So the providers, the individual providers, are bound by a formal agreement, and they're bound by this new care coordination component, which you see at the center of this figure. So this care coordination team is comprised of different healthcare professionals, and this varies by CCE, but typically includes mental health care coordinators, registered nurses, social workers, navigators, those types of folks. These are the folks that go out into the community, they find the enrollees, and they link them to the services that are provided by these individual providers, the member provider organizations. The state Medicaid agency maintained a relatively hands-off approach. So they viewed themselves more as a venture capitalist. They provided this initial investment and then kind of stayed on the sidelines. And that initial investment is, again, the capped number of auto-enrolled beneficiaries I mentioned, technical assistance to get the CCEs established, like the legal arrangements and data use agreements, and then some historical and ongoing Medicaid claims data for quality monitoring. So financing. Medicaid pays the CCE lead agency a per member per month fee, or a PMPM. The lead agency then uses the PMPM to cover the care coordination costs, so the labor costs for that workforce. In theory, the CCEs could use this PMPM for other costs of their choosing, such as housing. But again, because the scale here is so small, none of the CCEs we met with were really using this fee for anything other than the labor costs for the care coordination component. Illinois did not change the provider payment model, so all of the services that the individuals use are reimbursed through the typical fee-for-service arrangement the state has. The only thing that's new, newly funded, is the care coordination component. There's also no new housing resources or funding. So this slide, I show some of the key responsibilities of the care coordination team. Again, many of the enrollees are homeless. So the folks we spoke with, members of the care team that we met with, emphasized they spent the bulk of their time out in the community looking for these individuals, knocking on doors of relatives, checking shelters, local jails, churches, etc. Really trying to find these individuals and then engage them. So here I show 3 key ingredients, or 3 key takeaways. These 3 key ingredients are what the stakeholders we met with emphasized as being crucial to this initiative. One, as I mentioned, there must be capacity to assemble a care team that has knowledge of local resources, particularly individuals with experience or knowledge about housing resources. The CCEs we met with emphasized that they really looked to hire care team members with roots in the local community. And with a housing background, because they understood this was a significant need. Reimbursement for in-person care coordination. All stakeholders noted that these individuals, this target population, in order to see improved outcomes, must have in-person care coordination, and therefore there must be a mechanism to support this type of service. And then finally, a market for the type of care coordination provided by the CCEs. In the long run, the state did not view these CCEs as being sustainable on their own. They believed that if these CCEs could develop a cost-effective model for providing this type of care coordination service, that model would then become appealing to the larger state-managed care organizations that serve a much larger population. And that if the model, again, was shown to be cost-effective, these ACOs would want to partner with the CCEs to purchase their services. And sure enough, about a month ago, the state of Illinois has announced that effective July 1, they'll be transitioning CCE enrollees into a full-risk managed care plan. So the CCE contracts will not be renewed, although they will continue to exist. The CCEs now need to kind of formalize and solidify their relationship with managed care organizations to continue to provide these services. And a couple of constraints or challenges I'll note. Some community-based organizations lack the capacity to develop a CCE. State officials emphasized, or cautioned rather, that you shouldn't overestimate these types of organizations' ability to set up a CCE. So that the state had invested a lot of time and effort in helping these CCEs develop the necessary infrastructure to get them off the ground. Low enrollment, again, the state viewed this as critical, but the CCEs felt that it was a constraint. It prevented them from being able to do more. And finally, no shared electronic health record or client database. All the CCEs we met with had a system for tracking their encounters and referrals, but none of their tracking systems were linked to the individual databases of the individual providers. So there wasn't kind of data sharing across the individual CCE providers, and that was a significant constraint. So now we're going to shift gears entirely. Yeah. I can repeat the question. The question is, you were under the impression that the CCEs had been folded a while back and no longer exist. My understanding is, because they had a 3-year contract, which is about wrapping up. I saw the announcement from the state identified July 1st of 2016 as the date they would be officially moving enrollees out of the CCEs and into these other managed care organizations. My understanding is that at least 5 of the 6 are still in existence and still providing services. So now we'll switch gears, where the Illinois initiative is kind of an example of a nudge towards improved coordination. This next example in Massachusetts is, I think, an example of a more direct effort to improve coordination between housing and Medicaid. This is the Community Support Program for People Experiencing Chronic Homelessness, or CSPEC. CSPEC provides Medicaid reimbursement to care coordination support provided to chronically homeless individuals who are in permanent supportive housing. So the CSPEC providers are basically providing care coordination services to this population, and it's being provided through partnerships of local behavioral health providers and local housing providers. So the underlining belief from the state is that permanent supportive housing will reduce Medicaid expenditures. The state believes that, you know, by providing housing, you will stabilize the medical conditions of chronically homeless individuals, and so with that in mind, Mass Health, which manages or administers the state's Medicaid program, has authorized the reimbursement of CSPEC services, which is essentially care coordination support. They authorized this in 2006, so this program's been around for a little while. And the state's managed behavioral health carve-out, which is called the Massachusetts Behavioral Health Partnership, is the entity that's providing CSPEC services. And I'll get into that in a bit. But the goals of the program here are to stabilize and improve the lives of a high-risk, high-cost population, reduce the use of high-cost health services like emergency room visits in particular, and to reduce homelessness. So in CSPEC, housing is actually viewed as the medical intervention, right? So this really captures the essence of a housing first initiative. The idea is to divert resources towards serving individuals or treating individuals who are in housing rather than managing medical conditions on the street or in shelters. So the target population, of course, are chronically homeless adults in permanent supportive housing. These individuals must meet HUD's definition of chronically homeless, which I list here. They must also be members of the Massachusetts Behavioral Health Partnership. Again, this is the state's managed behavioral health organization. At the time of our visit, none of the managed care organizations in the state covered CSPEC services. But at the time of our visit, the state was rolling out a new pay-for-performance initiative through which they were hoping to create incentives for the managed care organizations to pick up this service. As far as I know, MBHP is still the only payer for this service. Between 2009 and 2014, MBHP served only 1,250 individuals. So again, we're talking about a small population, but we're talking about a very expensive population. I'll talk about financing of C-SPEC on the next slide, but this just shows kind of a high-level structure of the program. So again, MassHealth authorizes reimbursement of the services. MBHP has assembled a statewide network of providers to actually provide the services. There are actually 8 providers across the state, and their composition varies a bit. So 3 of the 8 providers are partnerships between a community mental health provider and a couple of housing providers. 3 other providers are a single organization that provides both behavioral health services and housing. And then the remaining 2 providers are a partnership between a federally qualified health center and 1 or more housing providers. So they differ somewhat, but what they all have in common is that they include a behavioral health provider that is in MBHP's provider network. Financing. So MassHealth classifies C-SPEC as a community support program service, and this gets into being creative with existing Medicaid authorities. The community support program is a different program that targets individuals who are being discharged from a psychiatric facility or a detox facility. So the community support program provides temporary care coordination to support to individuals being discharged, with the idea that this will help stabilize these folks' condition as they're leaving a facility. This community support program service has been around in Massachusetts, I think, since the 90s, and it was approved through their managed care waiver. So what MassHealth did was they took C-SPEC and they classified it as a type of community support program, therefore not having to seek out additional CMS approval. MBHP is reimbursed for C-SPEC through its capitation rate with MassHealth, and then the individual C-SPEC providers bill MBHP for the coordination support using a flat per unit per day case rate. All other services are reimbursed through the existing mechanisms. Again, the only thing that's new here, just like in Illinois, is how they go about funding the care coordination component. The C-SPEC services are provided by community support workers. So these are your frontline staff. Community support workers, many of which have lived experience, so there's a peer element in this as well. The community support workers are trained on how to provide or navigate both Medicaid and housing systems, so they are able to address the full spectrum of needs of these individuals. I list here the various responsibilities of community support workers. I will note that the ones we spoke with, they meet with individual clients on a weekly basis. So this is an intensive level of care coordination support. In fact, MBHP limits the caseload to 12, which I think is unheard of. This is 12, that's a maximum of 12 cases per community support worker. And the folks we talked with, the community support workers we spoke with, emphasized that the majority of their clients are not employable. A lot of these folks are still active users. Those who aren't using may not have daily routines or may lack independent living skills. So there's an intensive amount of work that occurs between the community support worker and their clients. And C-SPEC services are available indefinitely, as long as the individual maintains housing and maintains and continues to be in the MBHP plan. They can continue to receive these services. So again, here I'm showing 4 kind of key takeaways or key ingredients according to stakeholders for this initiative. One is the embracement of the housing first model. So Massachusetts is doing several other things to combat homelessness. C-SPEC is only one tool that they're using. In particular, the state has been investing in the development of low threshold housing. For folks who are familiar with that concept. I won't get into the details, but the takeaway here is that this program really is in tandem with several other efforts in the state. Again, reimbursement for in-person coordination is viewed as critical. Use of that case rate instead of the fee-for-service, the incremental model that's often used, was viewed as a positive. And again, having these local community-based health and housing partnerships are really the foundation of C-SPEC. A few constraints: program access is limited by the availability of housing and a subsidy. So even though Massachusetts is doing a variety of things to increase the inventory, housing remains, there still remains a shortage in housing. Service coverage gaps. So as I mentioned, MBHP is the only provider of C-SPEC. This is a particular problem for individuals who are dually eligible. So the managed care plans available for individuals who are dually eligible for Medicaid and Medicare do not cover C-SPEC. MBHP is not one of the dually eligible managed care providers. So when an individual becomes eligible for Medicare, which is inevitable, that individual is moved into one of the dually eligible managed plans. which is not MBHP, and so they lose eligibility for C-SPEC. This is a significant problem in the state. The C-SPEC providers we spoke with all noted that the community support workers, out of compassion for their clients, will continue to provide services without reimbursement, which is commendable but not sustainable. So this is obviously a problem the state is battling with. And finally, an insufficient supply of mental health services, particularly psychiatric services, which of course, as many folks know, is a problem that's nationwide. So case studies are great at bringing us to the ground, but I want to conclude with a couple of just high-level observations, both from what we learned from these two case studies, as well as a couple of other case studies that we conducted for ASPE with a similar focus. First, reimbursement for care coordination services is viewed as essential. This is seen as the glue that bridges all of these service systems together. Two, fostering local partnerships between Medicaid and non-Medicaid service providers is critical. Our service systems are siloed, but certainly individuals' needs are not siloed. They overlap and they're interrelated. So creating stronger linkages, especially on the ground between local providers, is viewed as critical. States are increasingly relying on managed care organizations to provide these types of services. Despite improved coordination, affordable housing remains scarce. So we all know this, there's not enough housing. And finally, service coordination and integration efforts are challenged by a lack of data. And we hear this from Medicaid state agencies that often note they have a blind spot when it comes to tracking and understanding the housing needs of beneficiaries. So we can assume that this challenge will become more important as more states take on efforts to improve care coordination between these service systems. And that, I will leave you with a couple of relevant publications for those who are interested. Thank you.
Thanks, Matt. Thanks, Matt and Carol. You can come on up, Jennifer. I was just going to take the opportunity to encourage folks, again, if you're online, you can begin to submit your questions on the Q&A panel, and we're going to get to them in just a second. And I wanted to reintroduce our guest, Jennifer Ho, who's going to talk about HUD's efforts in this area, and also feel free to comment on the last two presentations.
Great. Thanks, Jonathan. I cannot stand the thought of that sitting there, so let's go back to the one that says, despite improved coordination, affordable housing remains scarce. I first I want to thank the folks at Mathematica for inviting me to this conversation. We're here in a cozy room, but I understand that there's actually hundreds of folks that are signed up for the webinar. And so I want to say hi, in particular, to my friends in Baltimore. I know folks at the Center for Medicaid. We're definitely going to listen in. And a shout out to Martha and John, who are the essence of the HUD CMS partnership, but also to Emily Rosenoff from the Office of the Assistant Secretary for Planning and Evaluation at HHS. I think it's fair to say that over the course of the last 7.5 years, the collaborative work between HUD and HHS is unprecedented. And it covers a whole range of items. The work that we're doing on aging, the work that we're doing on disability, the work that we're doing on homelessness, the work that we're doing on healthier communities, healthier homes. It's really a broad range of things that we're doing together. The first question that I was asked to think about today was really about how money follows the person has changed the way that CMS thinks about housing. And I think there's a really simple answer to that, which is it made CMS think about housing. I mean, I think that that it was always there to some degree, but MFP just brought it into such stark relief that in order to accomplish the objectives of MFP rebalancing, that somehow or another the healthcare system was going to have to solve for housing. I've had some fascinating conversations out in Baltimore with different parts of CMS. And sometimes just some of these basic things, like housing's not an entitlement program, like Medicaid and Medicare, are new news to folks who have historically worked inside of those types of a benefit structure. The fact that you're eligible for HUD assistance means that you got a 1 in 4 shot of getting HUD assistance. And there's an extraordinary affordable housing crisis in America. And frankly, the work that we're doing federally, the investments that we've made, we're just barely keeping up, if not at times losing ground. So MFP changed how CMS thinks about housing in really, I think, profound ways. It's also changed the way that state Medicaid directors think about housing, and it's changed the way that managed care organizations think about housing. I knew that we were making progress when one of the large managed care organizations hired a vice president for housing. That was a signal that they figured out that it was a problem that they had to solve. I want to talk a little bit just about the many ways in which HUD and HHS, CMS in particular, have been working together. Carol, on your slides, you talked a bit about the non-elderly disabled vouchers, a thimbleful of vouchers to a fire of need, but still important learning and a way to introduce public housing authorities and the MFP folks at the state and build on that relationship, which, of course, if states can use their charm with housing authorities, they could get preferences for other resources that the housing authorities have. The 811 program has been extraordinary in terms of the partnerships that's created, but still a brand new program that states are figuring out how to work inside of the context of housing development. So the funding that you showed goes back quite a few years, but as of a couple days ago, 52 people have been helped. So again, just not operating at that scale. I was actually kind of surprised to hear that between 10 and 11,000 people are being transitioned every year. We are providing nowhere near that number of vouchers. So I guess the amazing fact is that these transitions are happening successfully when we are a very minor player. Don't tell Congress that. But I think it's pretty amazing. One of the first things that I did when I got to HUD in 2013 is helped get finalized some guidance that we did to housing folks about Olmstead, and did HUD-wide training, including work out in each of our 10 regional offices on Olmstead. Olmstead isn't something that housers have ever had to pay attention to. I considered a small victory that we got from people referring to it as the Olmstead Act, to understanding that it was a Supreme Court decision and how it tied in and what our role is. It's been very important to kind of elevate these issues because Olmstead impacts the whole portfolio at HUD, including old projects that we funded with statutory direction in order to create housing specifically for people with disabilities that is now considered congregate housing that's too concentrated, that states no longer want to have in their portfolio, and yet we have 30-year commitments on properties and housing. So we're really spending quite a bit of time out in the field looking at the portfolio of housing that we've either financed or we have a mortgage insurance on to really understand what part of that portfolio is, I'll say, at risk from our financial management side, but in transition in terms of the work that states are doing. So we get brought into this in kind of a very on-the-ground way. We worked really closely with the Center for Medicaid on the HCBS settings regulation. I'm sure all of you poured through all of the pages on the advance notice and the proposed rule and the final rule, but there's actually a fair amount of evolution that happened between early versions of the rule and later versions of the rule. And a lot of that, I think, is because of HUD's work with CMS to help them understand that where we have properties that are apartment buildings that congressionally were designated for individuals with disabilities, if we had put a hard cap on the percentage of people in a single building that could get HCBS services, that we would actually have made a whole bunch of people in their apartments in lawful buildings lose HCBS services. And so we're really grateful that our friends at CMS invited us into that process. And I think that what came out of it is a term feds don't say very often, but a very beautiful rule. It's that very kind of eloquently defines the quality of home. What is it that makes a home, as opposed to thinking that we should somehow define the configuration or the structure of the physical place. That home is a physical place, but more than anything, it's a place that supports our autonomy and our independence. So to work not only with CMS on the development of that rule, but also on the translation of it. It's a great tool for those of us who have worked in supportive housing on the homelessness side, as we really try to enforce a model of supportive housing that's about independence and autonomy. That's not about kind of structure, so structured that it would be on the verge of having more institutional characteristics. We worked closely with CMS on the informational bulletin that went out last summer on the use of Medicaid for housing-related services. We actually started a technical assistance project a couple years ago that CMS was a partner on called Housing and Health, H², where we actually worked with the recipients of HUD homeless assistance funding in order to help them reach out to their healthcare systems and think about those partnerships and think about the role that Medicaid can play in paying for services for people who are on the street and that transition into housing. And then very excited to be working with CMS now on the Innovation Accelerator Program, State Medicaid Housing Partnerships. It was interesting as we were developing it, I think that there was some concern that maybe there wouldn't be enough states that applied. And instead what happened was there was just this overwhelming response for states that really understood that they needed to strengthen those partnerships. We've also done work with the duals office, the office that's doing the Medicaid-Medicare coordination and the duals demonstrations. And it recently sat down with the leadership there, and what was the most striking is that, not unlike Money Follows the Person, the #1 qualitative early learning is that housing's a problem. And it's a problem because the managed care organizations that are a part of these demonstration projects are having a hard time finding people that get enrolled in the demos. And when they do find them, they're finding that some folks are in very precarious and unsafe housing situations. They're finding that some folks are homeless. And once again, because housing isn't an entitlement, there's not a magic wand to wave in order to solve for those things. So I think that really we're going to have the same learning experience happen as a result of the duals demos as we had with MFP. A couple other things that I would just mention. Working with ASPE and CMS, we did a pretty cool data match between people who live in HUD-assisted housing and their Medicaid and Medicare data, and looked specifically at the older populations of folks who live in HUD-assisted housing, and found that 2/3 of that population are dually enrolled in Medicaid and eligible, or Medicaid, Medicare eligible, and then that we're really seeing a population that has some pretty high costs and some utilization patterns that are exactly the types of challenges that states and managed care organizations need to solve for. So, on the one hand, there's not enough housing resources, and we have to figure out how to get those so that we can figure out how to align ourselves better with the healthcare system. On the other hand, we have these places that are where a lot of residents who are in need of better care all live in one place. And so I think there's extraordinary opportunity to partner in that way. I wanted to say our partnership with HHS extends beyond CMS and ASPE. We work with SAMHSA, HRSA, ACF, the CDC, lots of parts of HHS. And it informs a lot of the different work that we're doing at HUD. So just a couple things then in wrapping up. What are the important policy questions that this raises for me or for HUD? First of all, when you look at the healthcare system from a houser's lens, first of all, we don't understand a thing you say. The same way when you look at housing from a healthcare lens, you don't understand a thing we say. So just know that, right? I mean, when you show up in 1915I, a houser, it's an instant sleeping pill. So insofar as the healthcare system wants to engage the housing world, y'all are going to have to figure out how to speak English, because it's just really it's an important part of this collaborative work. And then you can't be off-put when we start talking about LIHTC and Section 202 and 811, these things that don't make sense there. Second, when we look at the healthcare system from a houser's world, the healthcare system is so siloed by disability type. Where people live is, we work with people that, have lots of different health conditions, lots of different situations, lots of different levels of need, but we might be trying to provide assistance to a broad group of folks, but the amount of support that's available could be completely dependent on what diagnostic categories and the doorway that somebody comes through. That needs to end, because we have to figure out how to provide these types of community supports to people based on their need, not based on their diagnosis and their need. And I know that the healthcare system, the specialty system, is arranged around diagnosis, but the housing world isn't. And so we really are hoping that one of the things that happens with Medicaid expansion and health reform is that states and CMS move away from kind of a diagnostic way of thinking about what people need. And I think that what we're finding in this intersection between health and housing is that these types of soft services, tenancy supports, housing-related services, it's not like what you do is different for somebody with schizophrenia than what it is that you do for somebody who has a physical disability and uses a wheelchair when we're talking about client engagement and the type of assistance that people need to move into their homes. And so I think that there really is a lot to be learned and understood about tenancy supports and the extent to which they're the same or different for different subpopulations. I think that there's an awful lot the healthcare system can learn from folks who, for example, have done street engagement on homelessness about client engagement. Things that have been somewhat flummoxing to states, for example, with Olmstead settlement agreements that haven't figured out how to do in-reach to people living in institutions, that they could learn from folks who do outreach on the streets. And then, the important policy question is, how do we solve this affordable housing crisis? And really, where is the burden going to lie? When I talk to states, I tell them, that the bad news is that the federal government is not racing to help in big ways on this issue, and so the pressure really might fall to states to fill some of that gap. And obviously, we're seeing that in states with Olmstead settlement agreements, where what we're bringing to the table isn't sufficient, and states are setting up their own programs. And it's not bridge subsidy anymore, because it's that bridge to nowhere if you're looking at waiting lists and things like that. Specific to behavioral health, I think some folks with mental illness end up on the street, some folks end up in jail, and some folks end up in the healthcare system. And historically, my sense is that the healthcare system hasn't cared very much about the people who landed in jail or on the streets. And I guess one of the hopes that I have is that with Medicaid expansion, that doorway is opened, and that folks who work in behavioral health will care not just about the patients who come to them, but the people with the conditions that need their care. We really need to figure out how to get this relationship between community support and housing right. I mean, I think the integration mandate of the Americans with Disabilities Act and Olmstead is key, and yet we have a supply problem. We need production. And so I think that we can't be purists in terms of how we think about housing models. I think that we really have to understand housing markets and the desperate need to do development, while also really understanding the mandate of integration. And then finally, on the point of integration, getting integrated care right. I think that that's still, to the healthcare system, is something that is pretty new. And integrated care oftentimes still means, maybe co-location. I love the line that people actually come to us fully integrated. It's the systems that are so siloed, but really figuring out how to get these systems to work together and deal really with all the comorbidities that we see in populations of folks with mental illness, but also, Carol, as your slide showed, the mental illness that is also underlying some of the other disabilities that you found in MFP. So challenges going forward. I took advantage of the fact that we were running ahead. I hope that's okay. It's just, so challenges going forward. Housing. I can't really even express what I believe is going to be the impact on the healthcare system of the magnitude of the affordable housing crisis. And I think that probably the best factoid I've seen recently that makes the point came out of the Harvard Joint Center on Housing Studies, looking at the housing needs of an aging America, the housing needs of older adults. It's a great study. It's short, too. But what they said is today, we provide housing assistance to 1 out of every 3 seniors who needs it. So we're more generous with seniors than we are with everybody else. But in order to keep pace with the growth of older populations and old and poor populations, age is the great equalizer. The older we get, the poorer we get, right? We would need to do 900,000 additional housing vouchers between now and 2030, just to keep up with only providing housing assistance to 1 in 3 seniors who need it. We are doing basically 0 today, other than the fact that we have people who have HUD assistance who are getting older. So we have kind of people that are just aging with their assistance. So 900,000 between now, so that's like 65,000 additional dedicated housing assistance for older Americans each year between now and 2030 to keep pace. And we're running about 65,000 units a year behind pace. I think one of the challenges going forward are just state budgets and how, I mean, we talked about Illinois today. You know, I don't think Illinois has paid a bill for 10 months. You know, we talked about Louisiana, where, you know, we're all benefiting from lower gas prices, but this is impacting Louisiana. This is impacting what they're doing in Texas. And so the vicissitudes of state budgets are driving state decisions on what they do with their Medicaid program, sometimes more than the longer-term objective of what do we know and what should we do in order to get better results in the long term. I think the Medicaid expansion population is an opportunity and a challenge going forward, really understanding who are the folks that didn't get in the system before and what is it going to do to take care for them. And then the ability of managed care organizations and nonprofits to create these types of partnerships where the nonprofits don't just get eaten. I can say that. I used to work for managed care. Scalability. I talked about these siloed population-specific orientations. And I think finally, I mean, just the last big question is, do we actually believe that better care will lower cost? Or are we constantly looking for ways to lower cost and pretending that we'll get better care? I mean, I think that's one of the great challenges going forward. So thanks for having me here, and take questions.
So I get to play moderator, if I could keep my microphone on. So we will maybe start with some questions here in the room, and then we'll go to the webinar to see if folks have questions there as well. So there's a microphone here that's gonna, or there, that's gonna wander around. So if you have any questions, just raise your hand and we can get to you so the folks online can hear.
Hi, my name is Cleese Erickson. I'm with GW University. And one of my questions is, given that all of you have talked about the challenges with affordable housing, I'd be interested in your perspective on what do you see as potentially promising solutions? I've heard of 2, and I think one of them was even alluded to today, about providing a housing matching service for people who may maybe not on their own be able to afford housing, but if you put them together can. And also, if there are opportunities in terms of helping people who maybe have housing that could be eligible who are nervous about it because of what might happen if the population moves in and out or damages the property or something, to provide some guarantees. I was wondering if you could comment on those solutions or offer other solutions that you see as maybe where we might go in the future.
Yeah, I mean, at HUD, we see home sharing as one of the potential strategies. I mean, most people, as they get older, are going to need help in their home. And if we can find a way to do that through shared living arrangements, it helps preserve people's ability to age in place, and it creates another housing spot where one didn't exist before, and whether that's having roommates in a home, whether it's accessory dwelling units, I think that all of that creates an opportunity. I mean, there are lots of ways in which communities do matching like that, sometimes not so well, the history of the child welfare system. Sometimes in really interesting ways, host home programs for LGBT homeless youth. So, I mean, I think it's not like it's an completely unexplored territory. But I also think that it's going to be a fundamental aging in place strategy, because if people want to stay in their own home, having somebody who is there that's not paid help, because we can't afford all that paid help, is going to be key.
Are there any other questions in the room? And then we'll go to the webinar.
Thank you for wonderful presentations and commentary. I wanted to ask about the role of area offices on aging. We know they have some involvement in MFP programs, but I was thinking about the evaluation that Mathematica did looking at Illinois and Massachusetts. Are area offices on aging at the table to help with the case finding and some of the coordination, since they're very familiar with the issue of affordable housing?
I'll at least speak to the ASPE studies. We were actually surprised that in both Illinois and Massachusetts, these initiatives really only involved the state Medicaid agency at the state level. Even the state housing agency wasn't part of it, nor were the AOAs. So no, they weren't involved. At the local level, there was a little more collaboration. For example, in Illinois, the CCEs I mentioned, one of them did eventually begin working with the local public housing authority. But it wasn't a requirement, and there was no state level coordination or encouragement of that.
Okay. Carmen, should we take some questions from online?
Yes, we have several web questions. This comes from John Sorensen at CMS. Several MFP programs that operate under a managed care model have included in their contracts with the MCOs that they have housing staff or do housing work in some form. Do you have any information on the productivity of these models?
In terms of the MFP evaluation, no, we haven't looked at those models in particular.
Hi, John.
And I think that's the same for the two states that Matt presented. Not so much in terms of productivity, but I think, as you pointed out, Jennifer, you've seen some movement in that area in terms of managed care organizations being more attuned to housing. I don't know if you want to comment more on that.
Yeah, I mean, I think the fact that money follows the person or an Olmstead settlement agreement has made states confront the fact that the housing doesn't just appear magically, has led to this housing coordination piece. I think it's interesting that the informational bulletin that CMS did talks about the fact that you kind of need this. It's not just the supports you provide to the person, but you need to kind of be able to build these landlord relationships, and you need to learn how to speak that language of housing, and having people on the team who do that's really important. I think that it's going to, that the housing sector isn't in a financial position to fund that type of work at scale. And so I think that the healthcare system is going to have to step in and fill that void.
I think a question here in the room that we can go back to.
Hello, my name is Amber Davis, and I'm a doc student at Howard University, and I'm in the social work profession. So my first question relates to Section 8 waiting list. And I've heard about lottery systems as it relates to Section 8 when, it's closed. And so I was wondering, how is it balanced with the lottery systems and prioritizing persons with disabilities when those waiting lists open up?
Sure. So thank you for going into this field first. There's lots of different ways that housing authorities can choose to prioritize different subpopulations on their waiting lists. And I'll say housing authorities do it in a gazillion different ways. So what you experience here may not be the same way that they're doing it in Houston or LA or someplace else, which is part of what makes the housing world complicated for healthcare folks to figure out. because it's different in many places. The same way that the healthcare system is different depending on whether you have private health insurance, Medicaid, Medicare, both, and which state you're in, right? So you can do a preference for vouchers that turn over. You can say like 1 out of every 8 vouchers that turns over, we're going to give it to an individual with a disability living in an institution. And you could reach down in the list and do that. You could say you're going to set aside 100 vouchers for that type of a project. You could project-base vouchers into specific units. So there's a whole bunch of different ways that it happens. So I think the dialogue with the local housing authority is critical.
We should probably take a few more questions online because I know we have a big audience there.
We do. This question comes from Alice Bousser with the Youth Law Center. Have any states or projects focused on young adults with serious mental health or substance abuse disorders or physical disabilities who are transitioning from foster care?
Probably the state that's done the most in this area is Ohio, and I'm not aware that they're doing anything in particular with foster care youth at all. But they have definitely had a focus in serving individuals with mental illness and in the various facilities that they work in. But I don't remember seeing anything about foster youth.
It seems to me that an interesting place to look for that would be states that have the child welfare 4E waivers and where they're working with young people who've been in the foster care system to older ages, because I think that that's where those issues would need to be grappled with, but I can't speak to any specifics on that.
Other online questions?
Yes. This comes from Peg Graham at QUA for CCE. Do they really need electronic health records with all the complexity and security challenges that are involved? Or can there be an app that they can use for limited communication with a care coordinator and who could manage data entered into the system?
I learned today that I have a light voice, so I need a second microphone here. It's a good question. I mean, I can only restate that it was considered a significant barrier to the care team that they were not able to easily access the databases of the individual providers. And all of the CCEs we spoke with, the 2 CCEs we spoke with, noted that despite that realization, they were not inclined to invest in developing a system. And that goes to the partial risk status of these CCEs. Again, although all of the providers were committed to the CCE model, they didn't need the CCE model to exist. So they would continue to provide services to their clients even if the CCE was dissolved. And so that creates less of an incentive to make these larger IT-related investments, I think. But certainly the types of technology that you mentioned would have been useful to the care teams.
There's just 2 quick examples that I don't know that an app would solve. And one of the things that's the most frustrating for people who are working with individuals that are chronically homeless who may or may not be in housing is not knowing when somebody goes into the hospital. Is the ability to manage the transition has everything to do with when somebody goes in. And likewise, I mean, if we have a HUD building, we know when somebody goes to the hospital because the ambulance showed up last night. But when we've got tons of people who are on vouchers and they just live out in the community, and I mean, if you're kind of doing a targeted care coordination piece like that, I also think health information exchange is, it's a baby. It will evolve, but it's nowhere near there yet. And so to ask some of these nonprofits, to invest in the startup costs on this stuff is pretty cost prohibitive.
I have a related question to data. You mentioned that there's a HUD, ASPE, CMS data match, and maybe without getting to too much specifics about what that is, do you foresee using that data match or other data matches to share data with states who can share data with local providers? Is there any kind of data you have at the federal level that could be sent to the local levels?
So Yes, there's a ton of stuff that's happening in the data match space. One of the projects that HUD's doing right now is to work with 6 states on a homeless management information system Medicaid data match. We've seen some communities already do this. It's helping them figure out, especially for Medicaid expansion populations, what the prevalence of homelessness or contact with the homeless system is. But it's also potentially a way for managed care organizations to find default enrolled members that aren't showing up at their door. I mean, we're seeing data match, and we're doing work on public housing authority, education system data matching. Now, data matching, big data is, whether we like it or not, I mean, I think big data is the wave of the future, and some of these strong state data warehouses where they can put the information together. HUD, for example, participated in Washington State to get the addresses of HUD-assisted housing to the state data warehouse so that they could look at an overlap between their systems and who's living in HUD-assisted housing. So I think there's a lot of opportunities there. I'm so struck in working with federal partners is that the data sits at so many different places, right? Sometimes it's a grant and the provider has it. Sometimes it's money that went to the state and the state put it out and the state has it, but the feds only have aggregate data. I mean, there's just so many different levels at which the data sits.
Hi, I'm Peggy Bailey with the Center on Budget and Policy Priorities. And Carol, I think this question's for you about money follows the person. Since it's a demonstration, one of the things we all hope is that we can figure out ways to make it sustainable, make it more a part of the Medicaid program. Does Mathematica have access to data that tells us more about what's working specifically in states, that kind of measures to look at outcomes, to look at housing stability, looking at some of those things that could help us figure out how to make the program more of a sustainable and more a part of the traditional Medicaid program?
Right. So part of our, well, a big chunk of our evaluation, it's obviously for CMS, and so we have been doing a series of analyses with the Medicaid and Medicare data. About 72% of MFP participants are duly eligible for Medicare and Medicaid. And so we've definitely been looking at what you would probably call more the medical outcomes. We've looked at things like reinstitutionalization, because one of the ways in which we think about measuring the effect of this program is not only can you get people into the community, but can you keep them in the community? And that is obviously going to be influenced by what kind of services you can put into place and keep people stable. And we get quality of life data, so we've been doing a lot of work with that as well. We have not, talking about a data match, we have not attempted to do any kind of data match with HUD data at all to try to figure out housing stability. And whether or not if you move out into one apartment or one home, do you stay there for a full year or do you move around? Do you become homeless? I mean, I hear anecdotal things, but we have not systematically looked at that particular outcome.
Sorry, thanks. I just, one of the points that I forgot to make is the tying to the things that states are doing, the innovative things that they're doing to those outcomes, I think would be really helpful so that we could make the case about this actually accomplished this specific thing so that we could work on that piece.
Yeah, more of that kind of analysis is being done at the state level where the state has the resources to do something like that. When, when you're evaluating and you're trying to take, our job is to look at all the states together. And then it becomes very hard to have the level of detail that you would need to have to do what you're talking about is, does this particular service have a particular kind of outcome? It takes a lot of resources to do something like that if you're going to do it across 45 different entities. And so we haven't gotten to that level of detail.
One more question here, and then we'll go to the online.
I'd like to follow up on the big data discussion. This is Clese Erickson again from GW University. And wonder how many people are actually using big data to point to how much money is actually being spent on the same people across different services to make the case at the local level or state level that investment in, that it's actually cheaper to house someone than to pay for all the emergency room transports and et cetera, like they have in Utah for their Housing First program. So I wonder if you could comment on others that are doing that, or if you know of other initiatives that are really trying to make the point that poverty can be very expensive to the system and you can figure out new ways to use money more effectively and improve quality of care. I was wondering if you could comment on that.
You started by asking how many. I was just going to say 12. Yeah, the biggest problem isn't the evidence that certain things can get better results. The problem is the way the federal budget's structured. And even if you prove that discretionary spending investment like a housing voucher results in reductions in healthcare spending, it's not scorable in Congress to be budget neutral in terms of making the investment in the next housing voucher. And so, I mean, I think the evidence is important because it's persuasive. I think also, at least what we've seen on homelessness, is that not a lot of the studies on cost offsets in the healthcare system broke down the difference between the payer. And so we need a much more sophisticated look at this, because whether it was a local dollar, a state dollar, or a federal dollar matters. I think that we're seeing more folks do this in more sophisticated ways. And as I said, I think it's the wave of the future, but it's not the wave of the past. It's not like we've got a ton of folks that are doing this consistently and well.
Great. Jennifer, we have another question for you from Daniel Davis at ACL. What roles do centers for independent living play as partners for coordinating housing and Medicaid services? And what roles can they play in the future? Are MCOs interested in funding community partners such as CILs and ADRCs?
Another federal partner that we work with that I didn't mention earlier, but I don't know the answer to the question. And I think that this is, I mean, where there are local partnerships, you know, we think people are trying to do this stuff better, but from a federal perspective, we don't know where the local partnerships are. And, you know, I mean, there are some projects that we have where we're intentionally fostering specific local partnerships. But across the board, I just don't think that we know enough. And I think there's an opportunity here for, you know, what's the trendy word, bright spotting, you know, where there are partnerships that are making a difference. But I really do think that oftentimes it's local charm and the you know, the willingness of people to work together in different ways.
So we just have another minute or two left, and I wanted to get a question in. So one of the things that strikes me about all of the presentations today, we've talked about this from both a systems level, kind of a macro level, what's happening at the federal level, the state level, and then down below on the ground. But one of the things that really strikes me is the importance of the workforce that's really out there on the ground doing the care coordination and engaging this really difficult to reach population. And Carol, you talked a little bit about some of the challenges that you've observed through the MFP grantees. Matt, you talked about that in terms of the intensity of the services that are provided through the two programs. And Jennifer, I think you mentioned the importance of client engagement as well. And I wonder if you all can share any kind of concluding lessons from the work on MFP or in the states or at HUD about how to sort of bring that workforce along and sustain it to really implement these care coordination efforts in a really high quality way.
Well, I'll start and then pass it on down the line. But in MFP, I would say there's two workforce issues that the states have grappled with. One is the care coordination piece of it and the people who do that and getting them adequately trained as well as having enough of them. And many times that's where they are relying on the Centers for Independent Living and AOA groups. to provide part of that assistance, but they have needed special training, particularly when dealing with people with behavioral health issues. But I think the grantees would say that it is one of the challenges of maintaining the program and maintaining the volume of transitions, is just having enough people do that work. I think the other thing that there was a few years in MFP where there was a pretty intense focus on the direct service workforce. These are the people who come in and help people do the activities of daily living. And that workforce is, the number of workers out there are not sufficient for demand. They are low paid, maybe in some instances poorly trained. So what the MFP grantees did a lot of work around was improving the skills, trying to develop mechanisms by which being a direct service worker could be more of a career, provide more of a career path, and in some cases even looking into the benefit structure, trying to do something around that to make it a more attractive work option for people.
I'll just very briefly note that in both Illinois and Massachusetts, the CCEs and the C-SPEC providers noted that there was a lack of funding for training this type of workforce, and that it was difficult to find enough individuals who can provide this level of intense care coordination. They really relied on individuals who expressed dedication to the position and had a real desire to do this kind of work. But they were otherwise relying on kind of a mix of funds to provide the types of trainings that they needed.
We're out of time, so Jennifer, do you have something quickly to comment on this?
Just building on what they say, when we pay people $30,000 a year to avoid a $30,000 visit, or seeing somebody who gets paid $300,000 a year, and there's just something messed up about that.
Thanks. Well, I think that's a great concluding point. So, but can't say it better. So, I just want to thank you all here in the room and folks online for joining us today. Tell us what you think about today by completing the card that's in your packet or online. And our next disability forum is on June 9th, where we're going to discuss some lessons learned from the vocational rehabilitation program. So thank you again. Thanks to our speakers.